parents of the kiddos that are in your office, they won't remember your brilliant cranial explanation. They won't remember flexion extension. They might remember like gag reflex, posterior parallel, different things like that. They will remember the number. They don't want a dissertation. They want a scoreboard. Attention chiropractors, slayers of subluxation, unleashers of the imprisoned impulse, and protectors of the developing brain. Welcome to the Cranial Doc Podcast, where we master the work that actually changes lives. Craniopathy, nervous system-based care, and the business systems that let you scale without selling your soul. I'm Dr. Anthony Pellegrino, pediatric chiropractor, certified craniopath, and proud automation geek. Let's dive in. Subluxation slayers, it is time to go over a very, very, very important concept today, and that is numbers. Who likes numbers? I like numbers, but here is the deal. Your parents, not your parents, but the parents of the kiddos that are in your office, they won't remember your brilliant cranial explanation. They won't remember flexion extension. They might remember like gag reflex, posterior parallel, different things like that. They will remember the number. They don't want a dissertation. They want a scoreboard. And if you're really clear, black and white scoreboard sucks, then your care plan, your retention is gonna suck. So here is the deal. I love scans. I love subluxation analysis. I love everything else like that. But any time that I am monitoring a patient's care, I need very clear, objective measures to demonstrate pre-post better or worse. For adults, we can use x-rays, we can look at curve angle, and we can see a degree change in curve angle. You can look at motion. You can see the number of segments that are stuck in flexion and extension and want to be able to improve that. In older children, you can use things like neurodevelopmental examination, which is going to look at, their reflexes, gross and fine motor movement, auditory verbal, visual cognitive processing, and say, these are the things that were negative, this is what are negative now. And it's just a clear, objective measure that isn't just a chiropractic measure. It is something that impacts their life and the other people that they see, right? It's something that's in their literature, unlike scans, right? And when infants, I don't want to just rely on what I'm feeling in myself and telling them, or the scans, but I want something very objective to be able to measure and look at. And we kind of change it depending on what it is that's going on and what we're finding. But what I feel that we come back a lot to is the actual measurements of the cranium. Now, our measurements of the cranium are very important because it gives a parent a really clear thing to be able to look at, right? Which is that they went from an 8mm imbalance and then they went to a 6. That is a positive change. Boom. Our goal is to get to less than 4. Okay, we're here so far. We're moving in that direction. Continued care. Our goal is to stay, we can look at all of that. And so today what we're going to talk about is specifically cranial measurements, why I don't like to use millimeters, the measurements that we actually do use, and a way that you can get a automatically generated report for you to use for your families for free, which is great. Okay, so when we are looking at measurements of the cranium, there are a few different measurements that we need to take and log. For us, we use the calipers, and they are very, very, very specific. So when you get the head calipers, I think they've come from Mimos, but the head calipers, there's also a band that looks like the Karate Kid that they need to go on. It has a circle for the glabella and an X for the EOP, and it needs to be on there so that you can get very specifically the angles, which I think are 30 degrees off for the right measurement and for the left measurement. So what you're going to do is you're going to use that band, and with your calipers, you are going to take 3 measurements and average them, okay? Because there is some uncertainty here. You're going to take, again, 3 different measurements of the A to P from glabella to EOP. There's X's for the right frontal to left occiput, which would be 30 degrees off of the, I think it's 30 degrees off of the midline A to P, which is going to be your right measurement. And you're going to do the same thing for left frontal to right occiput, which will be your left measurement. You're also going to take a measurement of the parietal bone at the widest point, and that is going to be your parietal width measurement. And then you're also going to do the frontal, okay, which is going to be your frontal width measurement. And you're going to take all of these. So the easiest back of the napkin thing that you're going to be looking at is going to be this right versus left measurement, which is the diagonal measurement, which is most important for plagiocephaly. Now, we've always looked at that in terms of just millimeter difference. Their pediatrician cares when that measurement is over 8 millimeters different, because that's when we're in helmet land. Some will do 8, some will say 10, but that is where they really start to care a lot. For us, anything over about 4 is really where we're going to get really, we're going to want to be concerned. So that's the easiest back of the napkin to just know, hey, I'm right there with the patient before I do math or anything else like that. If it's above 8, I got to tell them we really need to prep them for the ROF. We're going to have to be aggressive with this. You can also tell them to look at those different things as well. And if it's over 4, okay, it's not quite there, but we need to really be aware of this. I don't like to use the straight millimetric measurements as an objective outcome measure, though. And I'm going to tell you exactly why. Because if I start by seeing a patient at 1 week old, and let's say they have a 2 millimeter difference on side to side, they may have had their pattern improved, but as their head doubles in size, maybe it goes to 4 millimeters, but the head doubled in size, or maybe it goes to 3 millimeters, the head doubled in size. And so that means that, it looks like it got worse, but it actually got better, right? Because now we're accounting for the actual size of the skull as well, which is why instead of using the cranial vault asymmetry, which is just left versus right imbalance, we're going to use the cranial vault asymmetry index, which goes and looks and brings in that A to P measurement to account for the percentage of imbalance on side to side. So, okay, it went from 4 to 6 millimeters, but because the skull got larger, the actual imbalance index decreased and it did improve. The other measurement that we're going to look at is the cephalic index, which is essentially the max width divided by the length. What percentage is that? A bad cephalic index is going to be an indicator not of plagiocephaly, but of brachycephaly. And then the width, which is where we're going to look at, is the parietal over the frontal. And what we're going to be doing is we're going to be looking at what's called the frontal parietal ratio, which is giving us a good idea of, is our forehead kind of becoming too wide? Is there maybe a scaphocephaly sutural issue that we're missing? These are all of the different things that we really want to pay attention to. We put all of these numbers, analyze all of them, and generate a report. And when it comes to objective measures, that's a lot of what we want to be able to see the parents see improve. This is very important because they might be coming to us for something like, let's say, a reflux issue as a perfect example. And if you're like me, I'm a chiropractor who doesn't treat the symptom. But of course, what we know is that the parent doesn't give a shit. They need their kid's reflux and colic to be better. So we do a full evaluation and we're seeing, okay, yeah, there's, changes in range of motion, which of course we want to see improve. Maybe you do a range of motion measurement. So their parents isn't just, well, I think it's better. We want to actually know and prove it to them and to ourselves. But what we're also going to be looking at, okay, cool. So when they're feeding, when I'm noticing, when I'm doing my palate evaluation, there's this torquing there. The palate is uneven. It's high. It's vaulted. And we have a really big gag reflex in the middle of the palate when at this point it should be more posterior. I look at that, I see that that's a primary issue. I know that when the nipple goes back to that right side of the palate, they're opening up and now air is going in when they're feeding. That could be a huge issue why we are feeling colicky, because we're taking in all this air and gas, and maybe that's also contributing to sleep issues. It's also contributing to nervous system dysfunction. We're seeing all of these different layers that kind of come in, and that's all well and good, but a parent isn't going to be able to see the difference if they go into the palate. And end of the day, if you're from New Jersey like me, people who walk into your office, they're trusting, but they're also skeptical, right? And so they're not going to do an evaluation the palate is less high and narrow. It's okay, cool, I guess I'll take your word for it. But when we do a measurement, it just makes it a little bit more clear. So what we'll do is bring that back to the fact, okay, we're seeing this torquing in the palate. To me, that's a big piece of the puzzle. The range of motion in the neck isn't appropriate, which is leading to this sympathetic fight or flight response in your child's nervous system because they're not getting appropriate input to your brain. But what it's also leading to is this imbalance of the cranium. Right now, we see that it's an X percentage. Our goal is to get to here, but we're going to monitor that. We'll do an evaluation at this, and that's our goal. Is a parent going to ever say no to that, right? Oh, geez, that's the percentage. Let's get it. No, they're going to be all in for care. Instead of just using the millimetric imbalance of the cranial vault asymmetry, let's go a little bit more into the actual measurements that I like to use. And again, I'll kind of give you away at the end, hang tight. because I'm going to tell you an easy way that you can be able to calculate all of this for yourself. So the first measurement that I care a lot about is called the cranial vault asymmetry index. Again, it's the percent asymmetry based on the diagonals. So what we're going to be doing is looking at the millimetric difference from left to right and then dividing it, I believe, by the A to P axis, okay, by the A to P length. So what we would want to see, or basically in the literature what they describe, is an imbalance of less than 3.5% is within normal limits. 3.5 to 6.25% is going to be a mild plagio. 6.25 to 8.75 is moderate. 8.75 to 11% is severe. And above 11% is very severe. So some neurosurgery guidelines texts will say that anything above 3.5% is the only place where asymmetry is actually considered present and meaningful. That's really where we want to pay a lot of attention. What a higher cranial vault asymmetry index means is that there's more posterior flattening, offset posterior quadrant flattening, okay? Meaning that there's an imbalance on the left and the right sides of the cranium. What we know is that right flattening is going to cause left protrusion over time as that dural stress happens, and then you can start to actually, right flattening of the occiput will often cause frontal protrusion over time due to the asymmetry of CSF flow, due to the dural tension, which of course that's going to relate to TMJ dysfunction, jaw deviations later on as well. So we're looking at all of those different pieces. I love this pattern referred to by Dr. Lisa Geiger, who I love for this work. She calls this jet syndrome, which I like things that parents can ride onto. So jet syndrome is when we see this plagio pattern start to show up. What will classically go together is jaw deviation. One eye will look different size or shape or height than the other, and torticollis. So jaw, eye, torticollis, jet syndrome is how this shows up. So looking at this asymmetry, we should be monitoring that and trending that down over time, okay? We should be absolutely tracking shape and function. If the number improves and the kid still can't rotate left, we might be missing something, right? So this is just a piece of the puzzle. We don't live and die on it. But for our reports, it just makes it a lot easier. So we need to be able to own these measurements and really be able to, if we're an authority, again, this isn't about just using chiropractic measurements, but saying every profession looks at this index. They use this for their measurements. They're saying that doing the helmet is the way to fix this. So we might as well take those measurements and say, well, we also want to improve the same metrics. This is how we're going to do it and show that we actually did, versus just say, oh, hey, chiropractic can help with head shape. Like, no, let's show it. The next measurement is cephalic index. This is the wide versus long number. This is primarily a monitor of brachycephaly. How wide is the skull relevant to the length? So the normal will vary based off of eyes, but based off the age and population. But there's a couple of different anchors. A study of normal children found that a mean cephalic index of around 80 to 83%. The American Academy of Pediatrics relates that anything greater than 93% is where we would define brachycephaly, okay? Although many different papers have essentially challenged that as the brachycephaly cutoff, we essentially want to say, I don't really necessarily care what that is unless you need a referral. I care about, is it changing over time? If my parent is concerned about brachycephaly, can we measure it and say, this is how close you are, right? And before, do a helmet or not, but this is where we want to go to, right? When that brachycephaly number is high, you'll see a reduced posterior vault projection, meaning the occiput will look very, very, very flat. You will also start to see this big parietal and temporal bulge over the ears, which will be that classic presentation, which that can also relate to external rotation of the temporal bone and bilaterally, which will result in a massive jaw retraction, which of course goes with things like tongue tie, but we're just talking structurally, will retract the jaw bilaterally, which will cause a bilateral external temporal rotation, will retract the jaw. Even if both are externally rotated, one more than the other, it'll deviate, but it also will attract it. And that jaw retraction is going to be your classic overbite presentation, which of course is going to relate to sympathetic stress, airway issues, orthodontics issues, and everything else like that over time. So you can know that and communicate that with your parents. And then the last number that we use is the frontal parietal ratio. I call this the forehead story. So basically, what is the forehead width relative to the overall cranial width? So it's harder to give a universal number for here because there's lots of different ways to be able to calculate this in the literature. I like just the width of the parental, using the width of the parietal and the width of the frontal. But like there's studies that use CT to be able to calculate this. A number of about an average number of like 0.68 at 0 to 3 months has been found normal to about 0.65 by 19 to 24 months. So we're looking at a 65 to 68% as a ballpark typical range. If it's off, we might be showing some frontal bossing, meaning that the front is actually increasing size, which could be a number of patterns. If the FPR is low, it can be relating to like a Cephalic case, which is a measurement that we should know, especially if the head is appearing very, very, very narrow. And again, we want to monitor that and see how that changes. What we'll see visibly if that number is off is forehead symmetry in photos, less orbital asymmetry. We want to see less orbital asymmetry. We'll see that the cranial growth looks more centered. And essentially, our job is to take these three numbers and put this together and monitor change over time. Now, that sounds like a lot. So, of course, what I have for you is that I developed a calculator that gives you the exact numbers and will also give you an ability to create a report where you can see what normal, yes, no, where does this child fall in each of these different measures. If you want this, it's part of the normal email series from the Cranial Doc. So go to thecranialdoc.com. I don't have a way to sign up specifically for getting this index right now. If enough people want it, or you guys calculate it right now, if enough people want it, then I will make a way to use that as a lead magnet or basically putting your information on your email list. But here's the deal. Sign up at thecranialdoc.com. If you want this right away, email me back when you get that first email and say, can I please have the cranial vault calculator? And I will send you the link to that right away. Here are some really important things to understand. Again, we are not treating numbers. The numbers are an objective measure of what we are looking at. We're treating nervous system and mechanics. The numbers just really give us a measurement to be able to look at. I personally like to measure this about every 4 weeks, and I like to celebrate trend, not perfection, with my parents. I want to give them something to understand and look for, and I also want to relate this to the changes that they see in symptoms, but also improved range of motion, improvements in tummy time tolerance, improvements in latch and efficiency, improvements with sleep. These are different things that are important clinical observations, not claims that we're going to be able to make, but like clinical observations that we have where we know that when we understand what happens when the cranial vault is off, that's a way for the parent to be able to look at that. What we care itself isn't that the cranial vault is off, but we care more about the subluxations patterns underneath that are causing or relating that cranial vault to be off in the first place, okay? This just gives them an entry into this world and understanding, much like if you're doing corrective care, you might care about the subluxation underneath that's relating to the curve being off in a cervical spine, but to them, they don't care. They're just like, what's the number? It's 20 degrees. I want to go to 40 or whatever it is, right? And so this is an easy way for you to be able to measure and look at that and be able to deliver some certainty to your parents in your office. Again, cranial vault asymmetry index, cephalic index, and frontal parietal ratio. You can get a calculator for this by signing up at our email list at thecranialdoc.com. Catch you on the flip side. Thank you for listening to another episode of the Cranial Doc podcast. I hope you got a ton of value out of today's episode. And if you did, it would mean the world to me if you jumped over to iTunes or your favorite podcast player of choice and subscribed, rated, reviewed, and shared this episode with a friend that you know could benefit. We have a ton of this information and more in our free email series at thecranialdoc.com. So go ahead and jump on there, subscribe, and get me raw, unfiltered in your inbox every week, changing your practice. Can't wait to see you for the next episode.